Good evening, everyone. Welcome to the NAFTA webinar on this fine Thursday evening. Thank you for spending your time with us. Really appreciate that. We're going to give everyone some time to log in. And while you're logging in, and we're going to just stall here for just a little bit. I'm Phil Russo, NAFTA's Executive Director. I'm pleased to welcome you to tonight's session on Map It Out, Managing Hypotension in the Anesthetized Patient. But while we're waiting for people to join us, how about just dropping a note in the chat box, letting us know where you're watching from tonight? Where are you all coming from tonight? We want to get a sense of how much of the country of the U.S. we are covering. And I say that with great interest, and I say tonight with great interest because actually our speaker, it's actually this morning. It's actually Friday morning for our speaker. Our speaker is actually coming from down under, from Australia today. So Rebecca is joining us from a whole different day out in the future. So those of you from Twin Cities in Southern California, oh, we do have a Gold Coast, Australia. Fantastic. I thought
Yay.
I'd be the only one. That's really great. We've got people from all over. We've got Colorado, Michigan, Calgary. Thank you, Canada, for joining us as well. We're covering the US and Canada. This is awesome. I'm so pleased to see other folks from outside of the United States and Canada as well. It's great to have everyone here with us. Um, so Rebecca, thank you for joining us. And apparently you've got other folks who are early morning risers on Friday to join us as well. You'll also see on our screen Casey Kent, our good friend Casey Kent. Casey is the chair of NAFTA's Continuing Education Committee. The committee is the group that curated this topic for tonight. So Casey, how about if you just give us a little bit of a rundown of how we even got here tonight and how this webinar came to be?
Yeah, I'm so excited for you guys to see the lecture here tonight. And a special shout out to all my Michiganders. I am from Lansing, Michigan. So special, like, little shout out for you guys. But like Phil was saying, I am the chair of the CE committee, and I started back in January. And one of the first things coming on is I wanted to really take what you guys are asking for and give it to you. And so one of the first things that you guys are constantly asking for is we want elevated CE opportunities. There's a lot of the CE that is kind of repetitive, and there's not a lot out there that is intermediate to advanced. And I heard that, and I'm seeing the comments and doing all the things. And so the CE committee came up with our care umbrella, which is going to be expanding as we keep going. But one of the first things we came up with under our care initiative to expand our CE offerings is our VTS lectures. And so these will be sprinkled in throughout the year along with our sponsored webinars. But these specific VTS lectures are built for you guys, like specifically only from our VTS specialists. And they're actually, we're working directly with the academies. So people like Rebecca have actually been nominated by the academies. So this is all specialized. This is working directly with the academies. No one is self-promoting themselves. And so it's actually for you guys to bring all of these more advanced topics to the forefront to give you guys some more high level education and high level CE opportunities through NAFTA. So this is our first one, and I'm so excited. And I can't think of a better lecture to do than with Miss Rebecca. So back to
Thank
you,
you.
Phil.
Thanks, Casey. Thanks, and thank you for in the CE committee for all the hard work. I know you guys have worked incredibly hard over the last 7 months since you've been the committee chair and putting new programs in place and
Yeah.
having proposals before the board to do some really new and exciting things. And wait till 2027, members. Your doors are going to be blown off. CE committee is doing some great work. So before we jump right into things, just a few housekeeping things, and then we're going to turn it right over to Rebecca so you guys get into the meat of things. So for everyone who attends the full session tonight, you've got to go through the whole thing. You will receive a certificate for 1 hour of continuing education. The certificate will be uploaded to your NAFTA account in the NAFTA database in about the next week or so. So check there for your certificate. If it's not in your NAFTA account in the next week or so, just drop us an email at info@nafta.net and we can look into that for you. But it should be in there probably by Tuesday or Wednesday of next week. Second, if at any point during the session you have questions, please use the Q&A feature for that on your screen. Don't use the chat box. The chat box, you can talk to each other and you should be able to talk to each other on that, not just the panelists, so everyone can talk to each other. But if you put a question in the chat box, it might get lost as that scrolls by. So put it in the Q&A box. Casey and I will be watching that throughout the night. And then at the end of the presentation, Rebecca will handle all of those questions. So you can put them in there whenever. If it's an easy enough questions, maybe Casey and I will be able to handle those. If it's not, not, we're going to throw those over to Rebecca to have her answer those. And then finally, please be sure to provide your post-event thoughts and your comments by filling out the survey we send you after the event. Rebecca also has a QR code at the end of the presentation that you can scan. I'll drop a link in the chat box as well, so you can scan that. We absolutely need your input. And as Casey was just saying, this webinar was created for you, by you, because of you. So it's that type of input that we need to help shape the future webinars of this kind. So definitely fill out that survey as well. So thanks for your attention to those details. Without further delay, Rebecca Brangwynne-Smith is, yes, joining us from Australia. Thank you for that. She's a veterinary technologist, a veterinary nurse, qualified trainer, and an assessor, and a veterinary technician specialist in anesthesia and analgesia. She has more than 13 years experience in general practice, in emergency and specialist referral hospitals. She is employed as the learning and development lead at Queensland Veterinary Specialist, and also serves as a director on the board of Veterinary Nurses Council of Australia. We are honored and pleased to have Rebecca join us tonight, so please join me in welcoming her now for this presentation.
Thank you so much, Phil and Casey, for having me tonight. And guys, thank you so much for joining. I say tonight, but as Phil said, it is bright and early on a Friday morning here in Australia, so I'm joining you from the future. I do apologise for my non-Americanized spelling in this title slide, but I promise you I did go through and change most things throughout. So I'm very excited to share with you a little bit about hypotension today. So we will jump into it. Now, some things I'm going to cover in this talk today, we're still going to do a quick overview of what is hypotension. We're going to look at the physiology of blood pressure regulation, because that will assist us with our decision making with our anesthetized patients. We will have a look at some common causes of anesthetic hypotension, and then our systematic approach to assessment and troubleshooting, and then therefore our treatment and decision making. And if we have time at the end, if I don't ramble too much, then I do have a couple of scenarios that we can work through together so that you can put those skills into practice. So starting off, some goals of our blood pressure management. There's a few things we want to be achieving when we are managing our blood pressure. So we want to determine why our arterial pressure has fallen. We then also want to determine whether or not that this is compromising our cardiovascular function and potentially our oxygen delivery to our tissues and our major organs. And we want to be able to select an intervention that then addresses the underlying physiology that is occurring. So it is possible to have a patient that might have a low mean arterial pressure, but still reasonable cardiac output. They could have a normal mean arterial pressure, but poor cardiac output, or they could have an adequate blood pressure and cardiac output, but inadequate oxygen delivery to the tissues. So it's really important that we're not just looking at a set of numbers. We want to always interpret our blood pressure alongside the rest of our patients. So to start off with, what is blood pressure? So blood pressure is the pressure that is exerted by our circulating blood against the arterial walls. Arterial pressure varies throughout our cardiac cycle, and it's described using systolic, diastolic, and mean arterial pressures. So our systolic arterial pressure is the maximum arterial pressure that is produced during ventricular systole, so when our heart contracts. It is primarily influenced by our stroke volume, our ventricular contractility, arterial compliance or tone, and the rate at which blood is ejected from the ventricles. Our systolic pressure, therefore, provides useful information, but it doesn't independently describe our tissue perfusion. Our diastolic pressure is the minimum arterial pressure present during ventricular diastole or relaxation. Diastolic pressure is strongly influenced by our systemic vascular resistance, our arterial elasticity or compliance, and our heart rate. So if we have a markedly low diastolic pressure, it may therefore suggest a significant vasodilation, although we still have to assess the entire clinical picture. And then our map represents our average arterial pressure across one cardiac cycle. So our map is frequently used clinically as a surrogate for the pressure that is available to drive organ blood flow. So Normal heart rates, our MAP is roughly equal to our diastolic pressure plus a third of our systolic minus our diastolic pressures. And our pulse pressure is what is represented by our systolic minus our diastolic. Typically, that sits around 40 millimeters of mercury. So if you want to confirm those numbers, you can check your pulse pressure with the numbers that you have on the screen to see how potentially accurate it is, or if your patient is vasodilated. But the relationship between our mean arterial pressure, our cardiac output, and our systemic vascular resistance can then be simplified to this equation on the screen. So your MAP equals cardiac output times SVR, which you've probably seen quite a bit. Now, when we go into those even further, our cardiac output is the volume of blood that is pumped by the heart per unit of time. And that can also be expressed as cardiac output equals heart rate times stroke volume. So our cardiac output is therefore determined by both how often the heart contracts and how much blood is then ejected with each contraction. A fall in our cardiac output may occur because the heart rate is too slow, or it could be excessively fast. Our preload could be inadequate. Myocardial contractility can be reduced. Our afterload may be excessive, or we can have several abnormalities that are occurring simultaneously. Our stroke volume is the volume of blood that is ejected by one ventricle during each cardiac contraction. So our stroke volume is primarily influenced by our preload, our afterload, and our contractility. You may hear these terms a lot, but preload basically describes your myocardial fiber stretch at the end of diastole and clinically reflects the degree of ventricular filling before contraction. Our preload can be influenced by our circulating blood volume, our venous tone and venous return, intrathoracic pressures, ventricular compliance, and diastolic filling times. Our afterload is the resistance or the load that the ventricle must overcome to eject blood into the systemic circulation. For the left ventricle that is ejecting blood into the body, the SVR contributes substantially to our afterload. Increasing our vascular tone can therefore raise our arterial pressure, but excessive vasoconstriction may also increase our ventricular workload and potentially reduce our stroke volume. This concept is then especially important when we're using pure vasopressors such as phenylephrine, and we will go into a bit of pharmacology towards the end. And our contractility, or also known as inotropy, describes the intrinsic ability of the myocardium to generate force independent of our preload and our afterload. So reduced contractility means that our ventricle ejects less effectively despite being adequately filled. So we can therefore use our mean arterial pressure and our heart rate as indicators of our cardiac output, even though they don't tell us directly about tissue perfusion. So our MAP is equivalent to organ perfusion pressure. So it's a much better indicator of tissue perfusion than systolic pressure. Another important concept to understand is autoregulation. Now, this is the ability of the organs to maintain relatively stable blood flow despite changes in perfusion pressure. Within an autoregulatory range, vessels will constrict or dilate in response to changing pressure so that blood flow remains relatively stable. Once our pressure falls below the lower autoregulatory limit, further decreases in pressure may result in decreasing organ blood flow. However, our autoregulatory range is not a universal fixed number, although in textbooks you may see these numbers for cerebral pressure and our renal pressures. It may vary with organ systems, with species, with what anesthetic agent that you're using, and what concentration you're running it at. It could vary with our partial pressure of carbon dioxide or PaCO2. Chronic hypertension, obviously our pressures are going to be much higher. Potentially with neurological disease, systemic disease, and also individual patient physiology. So we have to take and treat every single patient as an individual and not just, fixate on one set of numbers. Studies do demonstrate that changes in cerebral blood flow as cerebral perfusion pressure, or CPP, is progressively reduced during isoflurane anesthesia, which illustrates why a single mean arterial pressure threshold cannot perfectly predict our cerebral perfusion in every patient. And similarly, other studies have demonstrated that renal blood flow and function do not always change predictably at one specific MAP threshold. Oopsie, oh no. Let's take that back. So hypotension, there is no single BP threshold that perfectly separates adequate from inadequate tissue perfusion. This is a really interesting research paper which surveyed ACVA and ECVA diplomats. And this found that intraoperative hypotension in dogs was generally defined at approximately a systolic pressure of less than 87 plus or minus 8. So, you know, we can look at 80 to 95-ish. And a MAP of less than 62 plus or minus 4. So we're thinking like 58 to 66 of mean, which is what they are agreeing equates to hypotension. European diplomats, interestingly, were slightly higher systolic arterial pressure, but otherwise they were all roughly the same and their treatment thresholds were roughly similar. For practical anesthetic monitoring and throughout this talk, we will use these thresholds. So a MAP below approximately 60 to 65 millimeters of mercury really should be prompting assessment of the patient and the cause of the low pressure. And in this circumstance, we're going to categorize our hypotension as mild of 55 to 60 millimeters of mercury, moderate as 45 to 55, and severe as less than 45 millimeters of mercury. Now, these categories, you know, while we're talking about fixed numbers here, again, it's on an individual basis. So these categories should support your urgency of decision making rather than replacing your clinical judgment. So, you know, a MAP of 58 millimeters of mercury in one patient that may have been stable for several minutes in an otherwise uncomplicated patient is very different from a MAP that suddenly falls from, you know, 80 down to 45 very quickly. So our trend, our magnitude, our duration, and our patient context all matter in our decision making. Now, you guys will have seen this before. We have many different ways of measuring our blood pressure, and I'll quickly speed through all of them so that we can focus on the more interesting stuff. But we can obviously measure our blood pressure with Doppler, I can never say this word, sphygmomanometry. So our Doppler probe detects arterial blood flow distal to an inflatable cuff, as you can see in the picture. So the cuff is inflated until that flow disappears and then is gradually deflated until our flow, or Korotkoff sounds as they're referred to as, or our cuff needle oscillation returns on the sphygmomanometer. These Doppler readings are commonly accepted as systolic arterial pressure in dogs, and in some cases in my hospital anyway, we interpret it as MAP in cats plus about 10 millimeters of mercury. But we really use Doppler for trends. I'm very lucky to work in a specialist hospital where we use a lot of invasive blood pressure monitoring. So we don't use a Doppler frequently, except for on our critical care patients or our really, really tiny patients that we can't get invasive monitoring in. So this paper here by Armour et al. Is actually quite interesting. When I was doing some research, this study found that the visual sphygmomanometer needle oscillations more closely agreed with our invasive systolic pressures when compared to the audible return of pulsatile flow. So this suggests that when performing our Doppler ultrasound blood pressure measurements in anesthetized dogs, if the needle oscillation precedes the audible return of pulsatile flow, it may represent our invasive systolic pressure more closely. Overall, both of these techniques did perform fairly poorly, especially when compared to published results for alternate NIBP techniques such as oscillometry. But where maintenance of arterial blood pressure within narrow margins is critically important, invasive arterial pressure measurement or a validated non-invasive measurement device, this paper suggests, should be used in preference of a Doppler ultrasound. But if it's all you have, then it is still good for using your systolic pressure as an estimate rather than an exact representation of your arterial pressures. This study therefore demonstrates imperfect agreement, reinforcing that value of trends rather than isolated readings alone. So Doppler still has lots of advantages. It can be used for any size patient. It's easier and less traumatic than invasive. It can be useful across a range of patient sizes, especially if you've worked with pocket pets and exotics. It does provide an audible assessment of your pulsatile flow, so it's nice to be able to hear that pulse. And the probe can remain positioned between measurements as well. There are some disadvantages that it only estimates your systolic or your mean, depending on what you utilize in your hospital. It can be difficult to detect a pulse with vasoconstriction or periods of hypotension, and there's obviously no arterial waveform to assess. And in some cases, this technique does require practice to use. Now, with our oscillometry, our oscillometric devices detect our pressure oscillations transmitted through the cuff during our cuff deflation. So our oscillations, you can see in this diagram, there's a lot of things going on, but our oscillations begin and that will be our systolic arterial pressure. And when they reach their greatest amplitude, that is measured as our mean arterial pressure. And then as the cuff pressure decreases, our last oscillation will be measured as our diastolic pressure. Each monitor uses a proprietary algorithm to calculate your systolic, your mean, and your diastolic pressures. And it is important to note that figures will vary between machines. Machines usually have, and models usually have different algorithms. So if you want to be consistent for your patient, I normally recommend using the same machine, the same cuff and the same location every time for consistency. It obviously still has a lot of advantages. It will give us 3 different numbers and a heart rate, usually. It is easier to perform than using a Doppler, and it is useful for trending. Most monitors now will usually give you a box of trends so you can look and see what is going on over a period of time. And it is automatic. You can set it and go, and it will read every few minutes for you, depending on what you set it to. Some disadvantages of this, however, is that accuracy can deteriorate with smaller patient size, movement. Obviously, we're not wanting our anesthetized patients to be moving, but it is possible. With arrhythmias, severe episodes of hypo or hypertension, vasoconstriction, and inappropriate cuff placement, oscillometric can be quite unreliable. I've worked with anesthetists that do call these devices just random number generators and they don't love them. But if it's all you have, again, I recommend using them for monitoring trends more than anything. Now, it is important that we are placing our cuffs appropriately. So it is recommended that we use a cuff width of 30 to 40% of the limb diameter. A cuff that is excessively wide or tight will tend to underestimate our blood pressure, and an excessively narrow or loose cuff will overestimate our pressures. So we do need to make sure that we're measuring these appropriately. And most cuffs these days will have a line that says that your tubing needs to go, or the bladder needs to go over where the artery is running. And they will have these useful guidelines for you as well. So if your cuff fits within those lines, you know it's going to be an appropriate fit for your patient. The cuff should ideally be placed on a relatively cylindrical portion of the limb or tail. So I usually recommend a forearm or around the metatarsals, or the tail if the patient has a tail. I tend to avoid flabbier areas like the hock on particularly skinny or lean dogs, because you have bone and then you have a flabby bit of skin and then you have your tendon and there's a lot of dead space, so the cuff is not going to read particularly well. But if you have something like a chunky Labrador, that area is perfectly fine. I also tend to avoid triangular areas like Frenchy legs that are just like trunks, funny shaped trunks. I would just avoid triangular areas because the cuffs are not designed to be used on that shape. Now, with our invasive pressures, our direct arterial blood pressure monitoring involves placement of an arterial catheter, which is then connected through non-compliant fluid-filled tubing to a pressure transducer. That transducer then converts the mechanical pressure into an electrical signal, which is displayed as both our systolic map and diastolic pressures. So we can see in red here, and we also get this beautiful arterial waveform. we can see this patient still has non-invasive pressure attached, and it actually matches quite closely to the arterial pressure, which is really nice because it doesn't always do that. And I'll show you some examples in a second. But this does give us some good continuous real-time monitoring for our patients. So if you have it available, it's a really wonderful tool to use. There are several spots that you can place arterial catheters. Now, our auricular artery is really good to use for dogs with giant ears, like this basset hound. So the auricular artery runs down the middle of the ear. You can also use your radial artery, which is on the palmar portion of the paw, of the forepaw. So it's generally where you will palpate that pulse anyway for a Doppler probe placement. It can be a little bit tricky depending on where that next paw pad is sitting, and you may need to bend your catheter a little bit to get it in. But I found really good success in large breed dogs, so it's quite a good spot to have it. You can also pop it in the coccygeal artery, which is on the ventral tail base. This is not great for long-term use, obviously very close to the bum. So for patients that are going to be in critical care, it's not suitable unless they have a rectal Foley placed. Otherwise, it's just going to get soiled. But my favorite spot is the dorsal pedal artery. So it's sort of on the medial dorsal portion of the hind paw, and it tends not to get bumped during surgery. It's a very reliable spot and it's fairly easy to place. So, and as a last resort, we always have the femoral artery, but I have never had to pop one in there, but it is an option. It would be quite difficult to secure. Whoopsie. Okay, so arterial waveforms obviously take some technical knowledge to understand how to read properly, but we sort of have 5 key areas where we're reading an arterial waveform. So we have our systolic upstroke, which is our inotropic phase, or where our ventricles are contracting. And at the peak of that is where our systolic arterial pressure is read. We then have a little bit of a runoff, and when the aortic valve closes, we have this dichrotic notch where there's a little extra push of blood out into the systemic circulation. And roughly below that is where our mean arterial pressure is being read. We then have our diastolic runoff, and at the bottom of that is where our diastolic pressure is read during our ventricular relaxation. And you can see here in these examples, our arterial pressures, which are both in red, compared to our non-invasive. So these 2 patients, the bottom one here was in an MRI, so we had a lot of tubing attached to this patient, and you can see how potentially you would want to treat these numbers as hypotensive, where our arterial pressure is actually reflecting that the patient is normotensive. So there are periods where you may potentially want to intervene with these patients if you only had non-invasive blood pressure monitoring available. But our arterial pressure is really good at sort of giving us more information. There is a little bit you do need to understand about damping as well if you use it. So over damping, you may see just sort of little knobbly bits like this. It can be caused by clots, by air bubbles in the line. Compliant tubing, meaning you can compress your fluid lines or bend it really easily and kink it, or you may have an underinflated pressure bag. A catheter tip could also be against the vessel wall. This will underestimate your systolic pressure and overestimate your diastolic pressure, so all of your numbers will be fairly close together. With an underdamped, it's sort of the opposite direction. Everything's very stretched out and quite dramatic looking. This could be from tubing that is far too long. We could have increased vascular resistance, or a catheter could be occluding the vessel completely. So this will overestimate our systolic and underestimate our diastolic, and therefore all of our numbers will be very stretched apart. So sorry, my computer is lagging. We can see that there are a lot of advantages to our invasive monitoring. We have a waveform that is produced. We have continuous real-time monitoring that is very accurate and works in periods of extreme hypo or hypertension. It is also useful during very rapidly changing cardiovascular conditions. So if you do more advanced surgical procedures, like in the chest or cardiac surgery, it's important to know what's going on pretty much at all times. Whereas when you're using a non-invasive pressure, you sort of only get a reading every few minutes or so, and things can change dramatically in a couple of minutes. So it is very useful for more advanced procedures, but there are still a handful of disadvantages. The system is obviously expensive to set up. It needs to be correctly assembled. It needs to be flushed and primed appropriately. It needs to be free from air bubbles, 0 to atmospheric pressure, level to the phlebistatic axis, and assessed for damping. So it requires a skilled technician to place the arterial catheter to then set up the system and interpret the results. So it is a fantastic tool, but it does take a lot of training to use as well. Now, my MAP is 50, so now what do? I like to use a systematic approach to assess my blood pressure. So first of all, is it real? Is my patient too deep? Why is my cardiac output low? And then how can I treat this? And we'll break these down even further now. So firstly, is it real? Before treating hypotension, we want to confirm that hypotension actually exists. So we want to perform a rapid patient and equipment assessment, which should take 30 to 60 seconds maximum. So we want to assess our patient, checking our heart rate and our ECG rhythm, checking our pulse quality, and does it match what is happening on my screen? I would even recommend auscultating the chest if you can, looking at our mucous membrane color and our capillary refill time, our oxygenation and ventilation, so our SpO2 and our end tidal CO2. You can still check your reflexes, your cranial nerve reflexes, and your jaw tone here to assess your depth. Your temperature, is your patient really cold? What surgical events are happening? Talk to your surgeons. Is there a visible hemorrhage? Ask them what is going on and see, does the monitor reading fit that patient? We then want to assess our equipment. So checking our cuff size and our placement, our cuff tightness, has our patient moved? Can we take repeated measurements just to confirm it? And what is the relationship between our heart rate and our ECG heart rate if you're using ECG? If you're using a Doppler, obviously check your signal quality, your probe position, your cuff size, and whether that signal is genuinely reappearing and disappearing. If you're using invasive blood pressure, we want to check our transducer zeroing and leveling, our waveform morphology, damping, catheter patency, air bubbles, and our transducer and tubing connections. Ideally, we should be using our trends. As I keep saying, I'm going to sound like a broken record by the end, but a single unexpected reading should trigger confirmation first. Repeated downward measurements are much more meaningful rather than a one-off low reading. Next, we want to be assessing if our patient is too deep. So volatile anesthetics produce dose-dependent cardiovascular depression. Potential consequences of this could be vasodilation, reduced systemic vascular resistance, myocardial depression, and reduced cardiac output. And obviously, isoflurane and other volatile inhalants are very common causes of hypotension in dogs and cats. We want to evaluate our cranial nerve reflexes, so checking our palpebral by tapping the medial or the lateral canthus of the eye. It should be brisk in light planes, diminished but still present in a light surgical plane and completely absent in medium and to deep surgical anesthesia. Our corneal reflex, we can touch the cornea very gently, and I normally will do this with a cotton tip or a Q-tip. The corneal reflex should always remain intact. If you lose this reflex, it signifies a critical overdose of anesthetic. We also want to monitor our glow position and our pupils. So the canine eye and the cat eye will rotate ventromedially during an optimal moderate surgical plane. Central eye position will occur if the dog is either too light or too deep. An exception of this will be dissociative anesthetic agents such as ketamine, which will keep the eyes fixed centrally and potentially maintain your palpebral reflex across the depths. Pupils will be normal to constricted in light planes, but will dilate progressively as you increase your anesthetic depth. But if you see a wildly dilated pupil like this, your patient is way too deep. Jaw tone can be evaluated by manually flexing the mandible. Resistance will increase as the patient lightens and will obviously decrease or become loose or flaccid as the anesthesia deepens. We could also use our pedal withdrawal reflex, so pinching that digital webbing. This will lead to a physical flexion or limb withdrawal, which may indicate that your patient is too light to tolerate surgical incision, but loss of that reflex indicates that they are at a moderate to deep surgical depth. Now, we also want to obviously track our autonomic and physiological traces. So anesthetists will track changes from baseline values rather than relying on strict static numbers. So sudden elevations in response to surgical stimulation point to an inadequate lightening plane. So spikes in our heart rate may happen during light anesthesia, but we will suffer progressive bradycardia in excessive depths. Obviously, our blood pressure will subsequently rise with noxious stimuli if the patient is too light, but we may drop into severe hypotension if your patient is over anesthetized. We may also see tachypnea, panting, or irregular breath holding in light planes, but we could have shallow breathing, hypoventilation, and apnea, which may point to a deeper anesthetic. So if depth is excessive, we obviously want to reduce our inhalant concentration first. Where necessary, we want to maintain adequate anesthesia and analgesia using max sparing techniques, such as using opioids, loco-regional anesthesia. We can add in adjuncts like ketamine, lidocaine, midazolam where appropriate, and other balanced anesthetic techniques. So our objective is not simply to turn our vaporizer down, but it's to provide adequate anesthesia with less cardiovascular depression. Moving on, we then want to look at where our cardiac output may be low. So this is where our equations are important. The key points that require assessment are going to be our heart rate, our preload, our contractility, and our systemic vascular resistance. And we will break all of those down together. So starting with the heart rate, we want to ask if this heart rate is appropriate for the patient and for the blood pressure that we are experiencing. So our heart rate should never be assessed using a universal numerical threshold alone. Bradycardia is defined as a slower heart rate than normal that is expected for the patient's physiological state. So a slow heart rate doesn't automatically require treatment, especially if your patient is normotensive. However, our cardiac output is reliant on our heart rate and our stroke volume. So if our stroke volume cannot sufficiently increase to compensate for bradycardia, a clinically significant bradycardia may then reduce our cardiac output and our mean arterial pressure. Tachycardia is a heart rate faster than expected for the patient's physiological state. So moderate tachycardia can support cardiac output. However, severe tachycardia can shorten diastole, which may lead to reduced ventricular filling, reduced preload, reduced stroke volume, and increased myocardial oxygen demand. Now, potential causes of bradycardia could be breed associated. We could have high vagal tone, especially in breeds like bulldogs. We could have opioid or alpha-2 adrenergic agonist administration. We could have excessive anesthetic depth, hypothermia, some vagal stimulation, or perhaps an ocular cardiac reflex if you're doing ophthalmic surgery. We could have hypokalemia and other conductional abnormalities, among others. So when is bradycardia clinically important? Really, we become more concerned when bradycardia accompanies the hypertension, if they have weak pulses, reduced end-tidal CO2, or perfusion parameters, or any conductional abnormalities and deteriorating hemodynamic stability. So we can use a couple of different drugs to manage our bradycardia. So atropine and glycopyrrolate are antimuscarinic drugs that reduce our parasympathetic influence on the heart. So glycopyrrolate can be used at 5 to 10 micrograms per kilogram IV, and atropine can be used at 0.01 to 0.02 milligrams per kilogram IV. However, upon researching, I realized that your atropine concentrations may be different. So maybe don't take my word as gospel when it comes to the dose rates. In Australia, our atropine comes as 0.65 milligrams per mil. So if your concentration and doses are different, please do those. Don't just take what I say as gospel. Now, atropine generally has a faster onset and usually starts acting within 1 to 2 minutes, whereas glycopyrrolate has a slower onset and a longer duration. Normally, it takes about 10 minutes to kick in, but it lasts about 1 to 2 hours systemically, whereas atropine anecdotally lasts about 30, 45, 60 minutes systemically. Glycopyrrolate, from experience, I find is less arrhythmogenic and has less severe tachycardic effects than atropine does. But obviously in emergency situations or in cases of cardiopulmonary arrest, atropine should be your go-to. We want to give it what we use of 0.04 mg per kg IV once as early as possible, especially in vaguely mediated cardiopulmonary arrest. Treatment should still address the cause wherever possible, rather than just reflexively administering an anticholinergic for every low heart rate. So we still need to look at all of our other parameters. For example, hypercapnia can promote vasodilation, so that will require ventilation to reduce our end-tidal CO2 to assist with resolving the hypotension. Otherwise, you're just going to end up continuing to repeat your anticholinergic. So glyco is my go-to, but obviously use what you have available to you. Now, tachycardia, possible peri-anesthetic causes will include pain and nociception, an inadequate anesthetic depth, so your patient could be too light. We could have hypovolemia from hemorrhage, or we could have dehydrated patients, and other issues we'll go into in a little bit. We could have hypercapnia, we could have hypoxia, we could have anticholinergic administration, which has then done the opposite effect and made our patients tachycardic, or other sympathomimetic drugs, as well as arrhythmias. Again, we want to be treating the cause, not the heart rate in isolation. Obviously, if we have a painful episode, we want to provide extra analgesia to our patients. If we have a light plane of anesthesia, we do want to increase our depth. We don't want our patients to be waking up. So we may need to increase our vaporizer concentration. We may, if our patient is tachycardic or has a normal heart rate but is hypotensive, we could administer an alpha-2 adrenergic agonist, which will cause vasoconstriction and a reflex bradycardia, and it will bring your heart rate down, but it will bring your blood pressure up. So that may be an option in this scenario. Or we could administer an adjunct like ketamine, lidocaine, midazolam to help increase our anesthetic depth. Now, hypovolemia, so the second thing we want to look at then is our preload. Is our preload appropriate? We've dealt with our heart rate. We then want to look at our preload. Potential causes of this could be hypovolemia, which can come from dehydration. It could be third spacing. We could have acute hemorrhage, and we could have gastrointestinal losses like vomiting and diarrhea. Ideally, we want to know, is there enough effective circulating volume returning to the heart? So other options of decreased preload could be obstructed venous return. We could have vena cable compression. It could be from positive pressure ventilation, which will increase our intrathoracic pressures and reduce our venous return, or we could have excessive PEEP, which is doing the same thing. We could have vasodilation, and we could also have low total body water in our geriatrics. Positive pressure ventilation deserves particular consideration because increasing our intrathoracic pressure will reduce the pressure gradient for venous return. So if we're over-ventilating our patients, that can be contributing to hypotension. So if I'm mechanically ventilating a patient, I will always look at pulling back on my figures and more conservatively ventilating them as an option first. Now, looking a bit more closely at hypovolemia, we have a bit of a cascade here. So why does preload cause hypotension? With hypovolemia, whether it's absolute or relative, we have a reduced circulating blood volume, which will reduce our venous return, which will then reduce our stroke volume, reduce our cardiac output, and then potentially reduce our oxygen delivery and our tissue perfusion. This will impair our cellular metabolism and also reduce our mean arterial pressure. So, Hello. So hypovolemia describes an insufficient effective circulating volume. So it could be absolute or it could be relative. Now, absolute hypovolemia is where we have a genuinely less circulating intravascular volume. So examples of this could be hemorrhage, there could be gastrointestinal losses, could be dehydration, or we could have third space losses. So fluid is going into the chest, the abdomen, potentially even the peripheries. With relative hypovolemia, the absolute blood volume could be normal, but the vascular capacity has increased because of vasodilation. So the available circulating volume is therefore insufficient to adequately fill the enlarged vascular space. So we want to assess our patient's hydration. When we are assessing volume status, there is no single variable that reliably diagnoses hypovolemia. We want to use our complete clinical picture again. So we want to assess our patient, assess their history. You should have looked at that before anesthetizing them. We want to look at our mucous membranes. Are they tacky? Are they moist? Our capillary refill time, is it normal? Is it prolonged? Our heart rate, our blood pressure trends. What are our estimated surgical losses? Have we had a hemorrhage? Looking at our blood work, so our packed cell volume and our total proteins and our lactate if you have it available. And this table up in the corner here is actually from the mini vet guide by Gerardo Poli. He is a emergency and critical care clinician on the Gold Coast in Australia. And this is really handy just to have nearby to sort of interpret your PCB and your total solids to see what potential causes of your highs and lows may be. Now, fluid responsiveness means that your stroke volume and your cardiac output will increase meaningfully following an increase in your preload. A hypotensive patient may be fluid responsive. They could be fluid unresponsive or fluid intolerant. So we can also use our pulse pressure variation if you do have invasive monitoring. So our pulse pressure variation describes respiratory changes in your arterial pulse pressure during positive pressure ventilation. This can be assessed subjectively using your arterial waveform, or some monitors will also give you PPV as a percentage. So if it's greater than 14%, it will indicate that your patient may be fluid responsive. Because mechanical inspiration changes, gives you changes in your venous return, we may have large respiratory variations in your stroke volume. So you can see here from this diagram, when your patient inspires, this trace goes up and then it goes down when they expire and so on. And you may actually see squishiness, for lack of a technical term, you may see squishiness in your stroke volume as well. So that can vary. The amplitude of your arterial waveform may change, which will indicate a change in your stroke volume. So this can therefore provide information about fluid responsiveness, particularly in appropriately mechanically ventilated patients. PPV, however, can be less reliable with spontaneous respiration if you have arrhythmias or very low tidal volumes in open chest conditions, altered thoracic compliance, and in right-sided cardiac dysfunction. So it should be interpreted, again, alongside the patient rather than used as an isolated fluid trigger. So fluids to bolus or not to bolus, that is the question. So remembering fluids are a drug. A fluid bolus should always have an indication, a dose, a rate, an expected endpoint, and frequent reassessment. So we don't want to administer repeated fluid boluses simply because our mean arterial pressure is low. Unnecessary fluid administration can overload a euvolemic patient, particularly when the primary abnormality is vasodilation rather than reduced circulating volume. With suspected absolute hypovolemia, we can administer a balanced crystalloid bolus, about 5 to 10 ml per kilo, over approximately 10 to 15 minutes, and then reassess all of the parameters that we just spoke about before. Response variables will include your mean arterial pressure, your heart rate, your pulse quality, capillary refill time and mucous membranes, your arterial waveform if you have it, and your PPV where appropriate. If you have hemorrhage and your hemorrhage is significant, it may be better to replace your red cell mass that it may be more appropriate to replace red cell mass than repeatedly replacing blood with a crystalloid. The crystalloid is just going to disperse into the extravascular space after about 45 minutes. So what we're worried about with hemorrhage is a loss of red blood cells, therefore a loss of hemoglobin, which will lead to reduced oxygen carrying capacity. So with hemorrhage and anemia, blood loss then produces two important cardiovascular problems. We have a loss of circulating volume, so we'll have reduced preload and cardiac output, and we have a loss of hemoglobin, so reduced arterial oxygen content. So therefore, repeating crystalloid administration may restore intravascular volume without actually restoring our oxygen carrying capacity. So that's why our PCV, our hemoglobin, ongoing losses in the whole clinical picture must be considered when deciding whether blood products are required versus just crystalloids alone. For suspected relative hypovolemia or vasodilation, you can follow the same steps for patient assessment. Consider a fluid challenge. I usually start with 5 mils per kilo, but you can do up to 10, again, over 10 to 15 minutes and reassess. But I would only give a fluid challenge if there are indications of fluid responsiveness. If hypotension persists following a bolus, consider inotropes or vasopressor therapy instead. It may not be a preload problem. It could be contractility or your vascular resistance. So to summarize that bit, because that was a lot of information, we can consider fluid resuscitation. We can do a challenge of 5 to 10 mil per kilo of crystalloids. Colloids may be considered, but they can be controversial. Anecdotally, I have used 3 mil per kilo of volumen or 3 mil per kilo of hypertonic saline 7% as an interim therapy. So your colloid particles are larger than your crystalloids and won't easily move out of the intravascular space. So they can be a reasonable choice for longer term fluid replacement while you are waiting for something else. We still need to consider transfusion triggers following a hemorrhage or if your patient is anemic. Typically at my hospital, we will transfuse a patient that has a PCV of less than 20%, or if we have total blood volume losses of greater than or equal to 20% intraoperatively, and we will transfuse whole blood because they need the red blood cells. Other things to consider are decreasing your ventilation pressures so we can increase our venous return. If there are any obstructions or compressions like GDVs, splenic torsions, and so on, we need to relieve that fairly quickly. And we've talked about transfusion. Now, the next thing I will be looking at is our contractility appropriate? So our cardiac contractility is the intrinsic strength and speed of the heart muscle's contraction, operating independently of changes in your preload and your afterload. So it dictates how hard the ventricles squeeze to eject blood, which is governed at the cellular level by calcium availability, among other variables. So is our heart rate pumping effectively? Positive inotropy means increased myocardial contractile force, and negative inotropy means reduced myocardial contractile force. Potential causes of reduced contractility include our volatile anesthetic agents, propofol and alfaxolone boluses, DCM, neonatal and juvenile physiology, hypocalcemia, and severe acidemia states. Management could include reducing our inhalant concentration or replacing them with a partial or total intravenous anesthesia, or adding in adjuncts. We need to correct hypoxemia if it is present, correct important electrolyte and acid-base disturbances if they are present, and ensuring that we still have adequate preload, and potentially adding in some positive inotropic therapy. Now, inotropes are drugs that will alter our myocardial contractility. So our positive inotropes, such as ephedrine, dopamine, and dobutamine, will increase contractile force and therefore increase our stroke volume, our cardiac output, and our arterial pressure. And again, we'll go into pharmacology in just a little bit. And then finally, I'm looking at our systemic vascular resistance. So is our SVR appropriate, or is our patient potentially vasodilated? Now, vasodilation is obviously widening of the blood vessels resulting from relaxation of vascular smooth muscle, and vasodilation will decrease our SVR. So possible causes again could be inhalant anesthesia. Those inhalants, they're just pesky little things that cause all the problems. We could have acepromazine and other vasodilating drugs such as pimobendan or ACE inhibitors if your patients are on those. We could have sepsis or distributive shock. We could have anaphylaxis, severe inflammatory states, severe arrhythmias, hypothermia and hypocapnia, among others. And management of profound vasodilation would again be reducing your anesthetic depth, considering a fluid challenge where it's appropriate, using adjuncts or replacing your inhalant with a partial or a total intravenous anesthesia. And then we're going to look at selecting cardiovascular support according to the physiology. So hypocapnia and hypothermia both promote vasodilation. We need to actively warm our patients if that's the case. We need to potentially ventilate or IPPB our patients if they are hypocapnic. Otherwise, we're not going to be able to resolve the vasodilation. We can still consider fluids if it's indicated. Otherwise, we can then look at vasopressors, and potential agents will include your norepinephrine, epinephrine, phenylephrine, and vasopressin. Now, vasopressors are most logical when we have low vascular tone that is contributing to hypotension. So the goal is not maximal vasoconstriction because our excessive vasoconstriction can increase our afterload, reduce our regional blood flow, increase myocardial workload, and potentially reduce our stroke volume, which is the opposite problem. Now, a little bit of pharmacology to sort of wrap up. There is some important terminology that I would like you to understand. So inotropy has an effect on our myocardial contractility. Chronotropy is an effect on heart rate. Dromotropy is an effect on electrical conduction velocity, particularly through our AV node. And our lusotropy is an effect on myocardial relaxation. Now, you will hear quite a bit about inotropy and chronotropy in this next section. And obviously, when we're talking about hypotensive patients, we don't want lusotropic drugs because we don't want to be relaxing the heart too much. It's already relaxed. Now, looking at a quick receptor review, we have our alpha-1 adrenergic receptors, which are predominantly located in the vascular smooth muscle. Agonism of these will cause vasoconstriction. They will cause increased systemic vascular resistance, increased arterial pressure. Our alpha-2 adrenergic receptors have presynaptic and postsynaptic alpha-2 receptors have multiple effects. So in the peripheral alpha-2 activation, this can produce vasoconstriction, and our central activation can reduce our sympathetic outflow, which explains why our alpha-2 agonists can produce a complex cardiovascular pattern rather than functioning simply like vasopressors. Our beta-1 adrenergic receptors are predominantly cardiac, and stimulation of these cause positive inotropy, chronotropy, and dromotropy. And then finally, our beta-2 adrenergic receptors are present in vascular and bronchial smooth muscle. Activation of these can produce vasodilation, bronchodilation, and some cardiac effects. So a majority of the hypotension management drugs that we're going to discuss now will act on our alpha-1 and our beta-1 receptors. So let's dive in. Now, first of all, ephedrine is a mixed sympathomimetic, predominantly with an indirect action. Ephedrine promotes endogenous norepinephrine release, so from the body's own stores, which produces both alpha and beta effects. Potential effects of these include increased vascular tone, increased contractility, increased heart rate, and increased mean arterial pressure. So it's particularly useful for mild to moderate hypotension, transient support, or a patient where both contractility and vascular tone may benefit. However, it does have a tachyphylaxis. So this means a rapidly decreasing response following repeated administration. So because ephedrine relies partly on endogenous norepinephrine stores, repeated doses may become progressively less effective as those stores are used up in the body. So it's recommended to limit repeated administration to approximately 2 to 3 doses. Again, the dose I use is 50 to 100 mics per kilo IV, but that is at a 1,500 micrograms per milligram concentration because we do dilute this down. Now, dopamine is an endogenous catecholamine and a precursor of norepinephrine and epinephrine. Its cardiovascular effects are dose dependent, which you can see in the table at the bottom right. So a CRI rate of 5 to 10 mics per kilo per minute primarily gives inotropic support and acts on the beta-1 receptors, where rates of greater than 10 micrograms per kilo per minute will give increasing vasopressor effects, and they will act on the alpha-1 receptors. So both ephedrine and dopamine can increase our blood pressure during hypotension. Potential adverse effects of dopamine, however, could be tachycardia. We could have increased myocardial oxygen demand and potential arrhythmias at high doses as well. So it's important to be titrating this to effect constantly. Now, dobutamine, again, is another inotropic drug. So this is a synthetic catecholamine with predominantly beta-1 agonist activity. Its main effect is through increased contractility, which will increase our stroke volume and increase our cardiac output. It's therefore particularly logical when reduced contractility is suspected. However, beta-2 mediated vasodilation may occur at higher dose rates. So consequently, we may have an improvement in our cardiac output without a dramatic increase in our mean arterial pressure. If our heart rate rises markedly while our MAP fails to improve, we may want to reconsider the dose, reconsider, is it a preload issue? What is our underlying physiology, and whether vasodilation is contributing and we need to use a vasopressor in addition to or instead of. And dobutamine CRI, we use at 1 to 5 micrograms per kilo per minute IV. Now, norepinephrine has strong alpha-1 and beta-1 activity. Effects will include vasoconstriction, increased systemic vascular resistance, increased vascular tone, and some positive inotropy. It's therefore particularly useful when we have a vasodilatory or low systemic vascular resistance issue as a major component of our hypotension. It's most useful, I find, for distributive or vasodilatory shock and septic patients. However, it does reduce perfusion to your liver, kidneys, muscle, and skin, and it can cause local tissue necrosis if it goes sub-Q. So I always use vasopressors in a secondary IV that is a clean stick. So you need to be really, really careful that it doesn't leak out of the intravascular space. We obviously want to start at the lowest dose and titrate up to effect. And this does have a fairly wide margin. So starting at 0.1 microgram per kilo per minute CRI, and then you can go up to 5 micrograms per kilo per minute. With phenylephrine, it's predominantly an alpha-1 agonist. Its principal action is vasoconstriction, increased systemic vascular resistance, and an increased mean arterial pressure. However, increased SVR will also increase our left ventricular afterload. So consequences may therefore include reduced stroke volume, reduced cardiac output, and reflex bradycardia. It's therefore best conceptualized as a drug for vascular tone rather than a treatment for every hypotensive patient. We don't want to use this aggressively to treat hypotension, as it can potentially cause vasopressor dependence and a detrimental loss of circulating volume. You can use this as a bolus dose of 2 to 20 micrograms per kilogram IV, or in a CRI at 1 to 3 mics per kilo per minute. And finally, vasopressin. Now, this is a potent vasoconstrictor that acts on our V1 vascular receptors rather than adrenergic receptors, so it can remain useful when our catecholamine responsiveness is reduced. Potential disadvantages of excessive vasoconstriction can include reduced perfusion to our extremities, to our gastrointestinal tract, as well as other vascular beds. So we want to use this at the lowest effective dose, again, for the shortest time as possible. We can use this in a bolus dose at 0.2 to 0.6 international units per kilo, or in a CRI at 0.002 or 0.006 international units per kilo per minute. It can still work, vasopressin can still work in acidic pHs, so in states of cardiac arrest or in severely acidemic patients, so that may be a good choice. Now, in cases of severe hypotension, a sudden and dramatic decrease in blood pressure should trigger a different level of urgency to trending downwards. So possible causes may include acute massive hemorrhage, we could have anaphylaxis, so severe vasodilation, could have closed APL valves, major hypoxemia, major electrolyte or acid-base disturbances, profound myocardial depression, pulmonary thromboembolism, severe arrhythmias, severe obstruction of venous return, or tension pneumothorax. So when I'm troubleshooting sudden severe hypotension, I'm going to do all of this in roughly 60 seconds. So I want to check, is my patient oxygenated, checking your SpO2, your oxygen supply, is there oxygen coming through your machine, checking your breathing circuit for kinks or disconnections. Does your chest wall actually move when you deliver a positive pressure breath? If your chest wall doesn't move, potentially you have a tension pneumothorax. Is your ventilation and circuit pressure appropriate? So checking your APL valve, checking for circuit obstructions, looking at excessive airway pressures, so checking your manometers, and thinking of a possible tension pneumo. Is your heart actually functioning? Checking your heart rate, your pulse, your ECG, your end tidal CO2, plus or minus your arterial waveform if you have it. Is your patient bleeding? Communicate with your surgeon, checking your surgical field, your suction canister, your swabs, and looking over people's shoulder and into the abdomen and thorax when it's relevant, so you can actually see what's going on. And then potentially thinking, could this be anaphylaxis or a profound vasodilation? If we have an abrupt hypotension, a cardiovascular collapse, bronchoconstriction, we may need to look at urgently getting some epinephrine to vasoconstrict these patients. Now, there was obviously a lot of info. So I did develop this little flow chart, which, you know, you've seen my social tags throughout, Pulse Academy. Feel free to check me out on Instagram. And this flowchart will actually be available very soon, but it's quite handy. I've been using it in my hospitals now for a little bit as just a quick go through to assess each stage of that. It's just a nice little flowchart that makes it easy for you to look through and make decisions, which takes a little bit of the thought process in a way. It can really assist with that decision making. Now, I have run a little bit over time, so we'll skip past the scenarios this time, unfortunately, to the end. Oh no, I've accidentally stopped my screen. That's good. 1 second, I will reshare. While that's all happening, I'd be happy to take some questions. I do apologize that my PowerPoint has dropped out, which is unfortunate. I will try and fix that in the background, but Phil and Casey, if you guys want to jump in with some questions, I'm happy to answer some now.
Great. There are a couple of questions in the Q&A. Casey, if you want to handle those, that'd be great.
Sure, yeah. I'm gonna send one to you that's a little bit longer, but in the meantime, if you're in a hemorrhagic situation in a place that does not have blood supplies on hand, what's the best way to try and support the patient's pressure?
That's a really good question. I think if you have, obviously you want your surgeons to be controlling the hemorrhage as quickly as possible, but I would still be looking at replacing that volume with crystalloid boluses to start with. So I'll be looking at administering probably 10 ml per kilo boluses at a time, depending on the severity of the hemorrhage. So we can assess our losses, looking at our suction canister and measuring that against what our patient's normal total blood volume is. I normally work out my 10, 20, and 30% preoperatively, so I can re-deliver fluids appropriately. And then if you don't have blood products, I would potentially consider a colloid like Voluvin or like hypertonic saline at 7%, 3 ml per kilo IV, just to sort of bulk out that circulating volume. Yes, you may lose some oxygen carrying capacity, but you still need sufficient volume to support your blood pressure. So I would look at 1 to 2 crystalloid boluses first and see how the patient responds, and then adding in a colloid if I don't have blood products available.
Perfect. I did send you one via private message that was a little bit longer. That way I'm not rambling on and you can quick read it.
Beautiful. Let me have a look-see. Oh my gosh, my Zoom is having a moment. Oh. Oh, there we go. Okay.
For those who can't read it, it's essentially a scenario one. So healthy cat, 19 months old, normal lab work, normal ECG, routine spay, and it looks like there were some issues with the blood pressure, um, and they were trying to address with propofol and giving a bolus. Um, it was the main question is based on your experience and studies. Um, should we have switched to a Doppler or not switched to a Doppler? Because it sounds like they were doing an automated reading.
Yeah, I would in this scenario, it's a cat, it's a smaller patient. Doppler is absolutely still appropriate to use. Non-invasive, as in oscillometric pressure, can be fairly unreliable in small patients. So Doppler is a nice alternative to have there. To compare. And again, I would be using trends still, which it looks like you've done. So, your NIBP may be showing you low readings. You've swapped to a Doppler, which is giving you consistent readings, as a systolic average, as you said, on the same leg. So that is absolutely appropriate to be using your Doppler in that way, as long as you're using trends rather than just single numbers on their own. So yeah, that's absolutely appropriate.
Are there instances for not mixing or running more than one vasopressor at once?
Other instances for doing it? Absolutely. Yeah, I
Well,
think if you
I
have
think what she's asking is, are there instances for not mixing? So either not
for
mixing
not,
them or running more than one vasopressor at once.
yeah, I think there are definitely scenarios where you can do more than one, or if you have like mixed potential causes of your hypotension. So if you think you have a contractility issue and a systemic vascular resistance issue, you can use an inotrope and a vasopressor together. I wouldn't use, like, if I think it's predominantly a preload problem, I'm not going to chuck vasopressors on because it's not going to increase my preload. So when I'm working down my my map of what to do next, I will be thinking of, do I need to give any drugs? What drugs do I need to give? But there are definitely, if it's a heart rate issue or a preload issue, inotropes and vasopressors aren't necessarily going to be useful. But I can't think of any particular scenarios off the top of my head where I would say don't mix them unless you only have a vasodilatory issue. Then using a contractility like a positive inotrope is not going to fix the vasodilation. So you just have to think of the physiology as to what is causing the hypotension and then treating it appropriately.
And the last question that I have right now is, do you have a specific protocol, blood pressure protocol for, oh, sorry, I'm sorry, this was in connection to the original one. The protocol for that spay was buprenorphine, dexamethasone, and ketamine for that big question that we had earlier. My
Oh,
apologies, I
yes.
should have added that. Sorry.
Okay. Yeah, I think it's still appropriate. So buprenorphine, dexamethasone is a good pre-med. And then do you say propofol and ketamine?
It
I
looks
think,
like it was Kitty Magic. So bupe,
yeah.
dex,
Oh,
medaz,
all in
ketamine.
one.
All
Sure, all
everything
in one.
all at once.
All the things.
All the things.
Yeah, I definitely use Kitty Magic sometimes, and it's great. But it is a lot of drugs doing a lot of different things all at the same time as well. So that's something to keep in mind. Do we need to? Yeah, it's a tricky one. I probably wouldn't give all of those things. I don't normally give benzodiazepines as an example in a pre-medication because I find it can cause hyperexcitability, but that's just from experience. However, when it comes to the anesthetic side of things, I think appropriate choices were made. If your NIBP is not effective, a Doppler is a good reason to change to that. And there's nothing I would really change in that drug protocol. There's nothing really there that I would say potentially is causing that hypotension apart from gas anesthetic, which is normally the number one contributor to hypotension.
And is the flow chart at the very end, is that going to be included in the resources that we are providing?
I can absolutely send that out, yes.
Perfect.
When it's available, I will send it through.
Yay, perfect. Yeah, if you guys, before I pass it back to Phil, perfect. Yeah, if you guys don't mind completing our post-event survey, it literally takes like 3 minutes. And the more data that I can get from you guys about what you want to see, who you want, not who, but like what things you guys want to hear about and learn about, the better that I can provide that for you guys. So please take just a couple of minutes and please complete that survey. I would really appreciate it. It's all you, Phil.
Thank you. Thank you, Casey, and thank you, Rebecca. So there's a link to the eval in the chat. There's been a lot of requests for the handouts. I did put a link to the Google Doc that contains the handouts in the chat as well. We're going to cover all our bases. You're going to get an email at the end, not today, probably by Monday, that'll have a link to the Google Doc with the notes, a link to the session evaluation. So please take care of both of those things. You download the document, fill out the evaluation, do all that good stuff for us. We really appreciate that stuff. Rebecca, I can't tell you how incredibly impressed I am with your breadth and depth of knowledge. It's just so impressive.
Thank you.
You know, it makes me so proud to be part of this profession, even in just the small way that I am. And I just, you know, I'm sitting here saying, I wish that every pet client could see 5 minutes of this. They would be blown away by what you and every vet tech knows and does. This was such a great example of the professionalism, the scope of knowledge, the expertise that vet techs have. I wish every pet parent could see this and know this. So thank you for doing such a great job of upholding the profession and presenting your knowledge and sharing your knowledge with all of us. We really appreciate that. Thank you so much. It's good stuff.
Thank you so much, Phil. Really appreciate you guys having me here today. And thank you so much for the participants who have joined me on your Thursday evening. Appreciate it.
Thank you. Thank you for joining us for your breakfast on Friday morning. Really great. One last word, though. We've got another webinar coming up on September 22nd. We'll be talking about another incredibly interesting topic of fecal microbiota transplant. Registration is required, but it's free for all NAFTA members. Just go to nafta.net, go to the calendar of events, click there, find all the information, register for free. It's another great night, great evening with us. So again, thank you all for joining us. Thank you, Casey. Thank you, Rebecca. Appreciate it. Great job, everybody. Thank you.
Thank you.